speaker. Maria Tassone is the Senior Director of the School of Continuing Education at the Michener Institute of Education at the University Health Network. And she is the inaugural Director of the Center for Interprofessional Education, a strategic partnership between the University of Toronto and UHN. Her experiences in collaborative leadership for health system change contributed to the development, implementation, and evaluation of the highly successful Collaborative Change Leadership Program, for which Maria is currently the co-director. Over the course of her career, Maria has been recognized as a leader and mentor with the 3M Innovation Award, the Ontario Hospital Ted Freeman Award for Education Innovation, and the Canadian Physiotherapist Association National Mentorship Award. Maria holds a Bachelor of Science in Physical Therapy from McGill University, a Master of Science from the University of Western Ontario, and she is an assistant professor in the Department of Physical Therapy, Faculty of Medicine, University of Toronto. Throughout her career, Maria has held a variety of clinical, educational, research, and leadership positions, both within physiotherapy and across a multitude of professions. She is most passionate about the interface between research, education and practice, and leading change in complex systems. Thank you very much for joining us today, Maria. Over to you.
Thanks so much, Laura, and I'm so delighted to spend a little time with you today. I was saying earlier, just before we started, that there's always work in putting together a presentation and thinking about the audience, but I'm really grateful for the opportunity today to actually have the time to pause and reflect on the work we've been doing across the university, Michener and UHN in particular over the last 9 months. And it was an opportunity to get re-grounded and re-inspired in the work we've been doing. So I'm really happy to share a little bit about what we've been up to, and then take some time to collectively think together about what we can actually institutionalize and mainstream post this pandemic. So the focus for today is, I hope to share some powerful examples about how members of our community have been engaged in rapid collaboration to really support healthcare and health education. As well, just to spend some time really elevating some of those key enablers or critical success factors across our education practice interface. And then together reflect, as I said, on what we've been learning and how we can really institutionalize some of those learnings. So whether these individuals know it or not, working with them over the last 9 months has really informed this talk. So I'm very much wanting to acknowledge members of the team at the Michener Institute, at the Center for Interprofessional Education here at the university, colleagues at Sunnybrook Health Sciences Center, and I'll say a little bit more about their role later, as well as Holland Bloorview, and all of the members of the Provincial COVID Care Learning Task Force that you'll hear a little bit about. So this context is not new for any one of us, but thinking back to March 2020, these were really the imperatives for us as a community in healthcare and in health professions education. We were thinking about how to quickly adapt to meet the needs of multiple people, communities, and stakeholders. We were trying to navigate the complex and, quite frankly, daily changing COVID-19 environment. And this has meant a fundamental shift in how we do our work and, of course, more broadly, how we live our lives. So with all of that as a backdrop, I want to share some pearls from our own learning. And the first vignette I'm going to share with you really points to this idea that collaborative leadership takes our relationships across systems and silos to new heights. So in the first wave, I had the great privilege of working with a fairly sizable team to really build education capacity building as people were being redeployed, both in hospitals and then in long-term care. And the way this started was a Toronto Region Steering Committee was formed back in late March to really deal with issues of capacity. And that was everything from ventilators and beds and what the model of care would be with the rising numbers, in the pandemic, but one of the streams was an education stream. And the education stream, which at the time was co-sponsored by Dr. Brian Hodges from UHN and the Michener Institute. He's our Executive Vice President of Education and our Chief Medical Officer. And so I was asked to take on the role of bringing together a task force to really think about how we could rapidly develop and implement, at the time, a critical care and acute care strategy based on a team-based model of care to help people prepare, be refreshed in their knowledge and skills, or perhaps take up some new learning to move into a practice environment that they may never have been in or hadn't been in a while. And so, as you can imagine, given that I'm speaking with members of the Faculty of Nursing, all interested in education, we brought together quite a diverse mix of people: educationalists, curriculum experts, people focused on evaluation, obviously a lot of subject matter experts. But we also brought in people who could really attend to some of the threads, as we call them. So experts in team-based learning and simulation were some examples of the provincial, but at the time, regional task force that came to be. And as I said, we were trying to respond to the urgent need, and I'll come back to the definition of urgent in a moment, to help people really bridge their knowledge from current practice to what they would need to be delivering high quality, safe care in the COVID context. And so within sort of a quick turnaround, and that quick turnaround was 10 days, which was incredible. We launched at the time what was the Critical Care Learning Platform. And this represents a collaboration, as I said, across a number of the health science programs at the university, but also the vast majority of our Toronto Academic Health Sciences Centre hospitals. The unique value of the platform was, as I mentioned, it was tied to a model of care framework that was developed by our colleagues at Sunnybrook under the leadership of Rue Tagger and Tracy Dasgupta, both members of the Faculty of Nursing, and was endorsed as the alternate model of care across the Toronto region and then later across the province. So the fact that it was team-based and interprofessional was a key feature of the design, but I'll come back to some of the key impacts around the learning in a moment. The way the learning platform was designed was that you, for example, as a nurse, could go in and find your particular tile in terms of nursing knowledge and skills, but you could also take advantage of any of the other professional tiles, as well as a number of content-related tiles related to, for example, infection prevention and control, team wellness and resilience, as well as the science of COVID. We tried very much to leverage existing resources. There was no time to create a lot of new content. So we sought subject matter experts across the system who could really help us curate the best available education and resources to be able to deploy quickly. And one of the things I've appreciated most about this learning platform is once people register, we have an ability to quickly communicate with users as new science emerges and new resources are added to the critical care learning site. So this was the model of care. And again, I just want to acknowledge our colleagues at Sunnybrook that was developed for that first wave of COVID. Luckily, we didn't need to move to this alternate model of care that would see patients being cared for in pods and in teams. And again, we did not also see the level of redeployment that we thought was going to be necessary in wave one. And now we await what's going to happen in the next few weeks in wave two, most unfortunately. So as we launched in April, on April the 1st, we as a task force, I think, did a pretty reasonable job of paying attention to what else was emerging in the system, both in the health education system and in the health care system, so that we could constantly adapt and add to the learning platform and the education strategy as needed. And one of the things I know we'll all remember is the rising cases in long-term care. And so within weeks of launching the initial platform, the Ministry of Health and the Ministry of Long-Term Care came to us and said, is there a way that you can build out the resources for redeployment to long-term care? At the time, hospitals were being asked first to solicit volunteers, as they called them, from within their staff to work in long-term care. And later through wave one, hospitals and long-term care homes were partnered in a more collaborative model to support long-term care in a more medium to long-term way. And so we had the good fortune of being able to collaborate with our colleagues at Baycrest and the Ontario Centres for Learning, Research and Innovation in Long-Term Care. We were particularly working with Raquel Myers, another member of the nursing faculty, and Lisa Sokoloff. And what we were able to do, similar to the critical care education strategy, was again curate a set of resources to help people in their redeployment to long-term care. What was different from critical care was that in critical care, we had professionals being redeployed in their own scope of practice. That was still true in long-term care, but we had many examples of respiratory therapists or speech language pathologists or hospital CEOs and other administrators actually being redeployed to function more as PSWs, to help support mealtime and as attendants. It was quite incredible to see, and I'm getting shivers just as I say that, to see the response. And so our job was to help people be comfortable onboarding into the long-term care context and to provide them a refresher in terms of some of the things that they would be doing. I should also say at the time, we rebranded the name of the learning platform to COVID Care Learning so that people could see themselves in the name of the site and not focus it just on critical care. A little bit different than critical care, where there was a model of care developed. Working with our partners from Baycrest and the OCLRI, we decided to actually go with more of a skills matrix approach. What were the key functions that each of the roles would need? And then we curated the education around these key functions. And in mid-April, we launched the long-term care stream. I will admit we were all working really long days, 14 to 16-hour days, and I'll come back to what kept us motivated and grounded to do the work. But as I said, the initial launch was 10 days. We were able to scale this work across the province by the third week of April with some funding from Ontario Health to support the digital infrastructure. We created a help desk model and onboarded 192 hospitals and their IT leads within 48 hours. I've already mentioned some of the collaborations, and by the time we finished what I'm calling phase one, which was mid-July, we had 16 professions-based streams on the site and 6 content streams, of which I've mentioned a few. Some of the others include team-based models of care and bioethics. So I wanted to share just some sense of impact of this work. Here are some user voices. On the learner front, and the University of Toronto did make this resource available to all of its health sciences students and trainees. And so we did get some wonderful quotes from learners. Here's one in particular from a dermatology resident who was going to be redeployed. And just the idea of being able to go to a centralized place with all of the resources versus trying to look for things on their own was really of value. A second quote from one of our new nurses at the Princess Margaret Cancer Centre, where they recently had one of their units converted to a COVID-19 unit, and just seeing the value of the learning for people not necessarily working in acute care and critical care, but working with cancer patients. A quote from a senior leader who had not worked in clinical practice for decades and volunteered to go into long-term care, and feeling that sense of safety for herself and safety for the people and residents that she would be working with, being able to actually review in particular all of the infection prevention and control learning and measures that were built into the site. And then the last quote, one moment of what I'll call serendipity when a health professional colleague was chatting with a healthcare team member up in Northern Ontario about a family member who was sick in intensive care, only to learn that they'd been using critical care learning as a resource to care for their COVID patients. Also wanted to just say a little bit about the reach of the learning platform. As of yesterday, there were just over 10,700 users across the province, spanning 50 different professions and all 14 local health integration networks. And I've got those two starred because when we look at the demographics, they very much match where the highest cases of COVID-19 exist. So we were really pleased to see that, as well as the core professions involved in that team-based model of care. So we think we kind of hit the mark with the demographics. And when I think about the reach of the collaboration itself, it's over 60 people and organizations. It's been quite incredible and probably the most rapid collaboration I've ever experienced in my career in healthcare and health professions education. In terms of overall impact, we have done some short-term evaluation, and from the data we have, we've been able to see that there was a sense of enhanced redeployment readiness, learners feeling that they were safe for themselves and feeling that they had the information and knowledge to be able to care for patients and residents safely. People very much took advantage of the team-based learning, and I think the need and the case for interprofessional education has been amplified during this pandemic. We've been able to provide and enhance resources for our students and trainees. And I think from a financial point of view, having a central resource for the province has been able to allow us to steward people and financial resources effectively, and we certainly can't forget that. I want to come back to collaborative leadership because that was the first pearl, that collaborative leadership can really take our relationships to a new height. And you heard in Laura's introduction that I have the great privilege of co-leading the Collaborative Change Leadership Program that's been in place in Ontario for just over 10 years. And these are some of the principles that we teach and we practiced in the development of the COVID Care Learning platform. Not just having a purpose, a common purpose, but a passionate purpose. Everyone who participated in that provincial task force was really guided by the idea that we were doing something meaningful, particularly for those of us who weren't directly caring for patients and residents. We also created some principles, what you can call kind of group norms to guide our work. We worked really hard to create moments for meaningful engagement, but also be mindful when we didn't need to waste people's time and just make some quick decision. We aimed for crystal clear roles and responsibilities on this massive project of 60 people and organizations, but we took time where we needed to really attend to the process of co-creation so that we could have a sound product of learning. And while we aimed for the best possible education, we were moving fast. So we had to acknowledge we weren't going to get everything right, and we just needed to learn and adapt quickly. So these were some of the collaborative leadership principles that I wanted to be explicit about that I think were critical for success. So that's vignette number one. Pearl number two, I wanted to share as an initiative that was integrated into the COVID Care Learning platform, but came out of our clinical education portfolio at the University Health Network. And this is a vignette about the need to be expansive in building a diverse interprofessional team and also expanding our definition of who is a member of the team. So one of the things we were noticing, going back to that idea of paying attention to what's emerging, is that, and this is not new for any one of us, there was an extremely rapid pace of scientific discovery, and therefore a lot of issues around accuracy of information, quickly changing information, and given everything that was happening south of the border, a lot of misinformation. And so we really started to think about our librarians as our information leaders and information specialists. And one of the threads we built into the COVID Care Learning platform was an information science lens. We have a particular tile on the changing science of COVID. And that was this particular project. So as our librarians or information specialists started to get a lot of questions about the science of COVID, they quickly realized that they wanted to put a resource together that could help give and provide answers to some of those questions, because they were getting the same questions over and over in those early days and weeks, and also curate the responses in a way that was accessible. And while we have it integrated on the COVID Care Learning platform, the Science of COVID platform also stands alone. And I just wanted to show you a screenshot of it because it is publicly available. And so anyone can access this resource portal. It has a lot of wonderful information, and it's constantly updated and curated by our librarians at the University Health Network. So a big thanks to Mandilo, who leads that portfolio, for the work that they've done on the portal alone and really enabling us to build it into the COVID Care Learning platform, as I said. So the third pearl is really about leveraging strengths. You know, we could have spent a lot of time thinking about, gosh, what are going to be the barriers to creating these new resources? How can we possibly do it in 10 days? But then pausing and saying, okay, but where are we already doing this? Who's already doing this work? Where are examples of where this is already working well, and can we leverage those strengths? And so a couple examples back at one of the places where I work, the Michener Institute, which not called a college, is one of the oldest post-secondary institutions in Ontario, over 60 years old, focused on the applied health sciences. And so Michener has a School of Applied Health Sciences. And in the new year, we'll be formally launching our second school, the School of Continuing Education, that I've been working with a team to develop and lead. Over at UHN, we also have been really lucky to bring in, as now part of our education family at Michener, the D'Souza Institute, which some of you will know is a provincial resource that started about a decade ago to support oncology learning and education in the nursing profession, and later expanded to content related to palliative care, and took on a more interprofessional approach. And now they have many social workers and psychologists, for example, taking part in their programs. One of the jewels of the D'Souza Institute is not just the education, but the hidden figures in the background who enable the learning platform, the things I don't know a lot about. And so in this particular project, which is a collaboration between Michener and Public Health Ontario, we brought together the strengths of the School of Applied Health Sciences, the School of Continuing Education, and the D'Souza Institute. This program was meant to support the need to be able to do testing for COVID-19. And I think we all know the volume of testing is large, and the health human resources to deliver on those needs are shrinking. We've known for years that we don't have enough medical laboratory technologists. And so this program, as I said, was a partnership with PHO to take science grads, so people who have a master's or a PhD in science and have learned or focused on microbiology or genetics, and have been working in our labs across the province in a research capacity, not a clinical capacity. And so we curated an education program taking from our full-time program in medical laboratory technology, our bridging program for internationally educated MLTs, and some of our continuing education courses in the lab field, to build a resource that could take these science grads to a place where, with some lab support, so they have been coming on site at Michener to do some lab work, to be able to work in our labs. And so what they've been doing is playing a role in preparing the COVID-19 tests so that they can be passed on to the med lab technologists for further analysis and meaning making. And so this is a really nice example of extending the healthcare team within the laboratory context. We brought the same group together, this time from the School of Continuing Education and from the D'Souza Institute, to build what was launched last week as the Ontario Workforce Reserve for Senior Support. And this time, we've been working to support the new resident support aids that have been launched just in the last week. And again, here we also leverage the strengths of our colleagues at Baycrest and the Ontario Centres for Learning, Research and Innovation. So our relationships have really been key through this time. The last couple of vignettes I wanted to share now come from the Centre for Interprofessional Education. So I spend about half my life at Michener UHN and the other half at the University of Toronto at our Centre for IPE. So this pearl is really about paying attention to what's emerging, which I've said before, and it's probably important to say that none of these individual pearls apply to just one vignette. They really cross all of these stories and vignettes. So at the Centre for Interprofessional Education, we partner with the Council of Health Sciences and the 11 health science programs at the university to continue to evolve a requisite IPE curriculum for our entry to practice learners. But we also have a very robust faculty and professional development set of programs. And that's really important and unfortunately still unique in Toronto, the need to ensure that what we're teaching our students is being modeled when our students go into practice. And so we have a number of programs geared at clinical faculty, at clinical leaders, to really build their knowledge and experience in interprofessional education, team-based care, and collaborative leadership. One of those programs is our EPIC program. It has been running for about 16 years. It stands for Educating Health Professionals in Interprofessional Care, and it's a 5-day faculty development program that we offer here in Toronto every June. But it's also been available as a customized 3-day program that we've taken around the world. And the center just went through its second external review a couple of weeks ago. And I think a very successful review. We're just waiting for that report from our external reviewers. But one of the statistics around the EPIC program is that in the last 6 years, we've actually had 26 international collaborations around this program. It's quite incredible. It's our foundations program in interprofessional education. And at this time, we have about 2,000 alumni from the program around the world. But last June, we couldn't offer it in Toronto. And with everything else going on, we made the choice to just pause on the program. We did not take it virtual because we just finished a 10-year evaluation of the program and its impact. And we saw in the data significant evidence of transformative learning for our learners, both as professionals, as educators, but also in terms of who they are as human beings. And one of the recommendations from our alumni was never to put this program online. Now, I'm going to come back to that because we've taken many of our other programs online and we're starting to see that virtual learning can enable transformative learning. And I was one of those naysayers, and I think I'm going to be proved wrong. But what we did in terms of the spirit of paying attention to what's emerging is notice that we were getting a lot of requests for how do we support virtual interprofessional teaching and learning. So what we did was we pulled on some content from the EPIC program and a few of our other programs and launched a new program in the midst of COVID-19, now called VITAL, which is Virtual Interprofessional Teaching and Learning. And who would have thunk it, but this is incredibly popular. And we're having requests from the US, from Australia, and from different parts of Europe, never mind our own local community, to really support team-based learning in the virtual space. So it's turned into another faculty and professional development offering at our Centre for IPE. The last pearl that I wanted to share, and this speaks to some of the details, the devil is really in the details, that we need to deeply consider as we go through this pandemic and think about teaching and learning, the hidden figures that are needed for success. And as I mentioned, our IPE curriculum at the University of Toronto has many, many different professions, thousands of students on an annual basis involved, all of our teaching hospitals. In fact, we have about 26 hospitals in the GTA that we work with closely, and 500 different facilitators of learning, both within the quote walls of the university, but also within practice settings. And what we were charged with as we came towards September, August, September, and the start of the new year was how we were going to fully shift to virtual learning. And so we've given a lot of thought. This is all still very much an experiment, but we're starting to learn some things about what it takes to enable a very rich learning environment in the virtual space. And one of them has actually been adding to our faculty roster and adding additional tech support. Now, these are not necessarily technical people. They are educators who are well versed in how to use technology. So they tend to be our younger faculty. And having that extra pair of hands that can deal with breakout rooms and logistics when they go wrong and keep things organized, the level of planning for our programming has been intensive, to say the least. But one of the things we're also learning is to keep it low tech. When you move to the virtual environment, you can get tempted to use all the bells and whistles that are available on the different platforms. But if it's about team-based learning and it's about rich conversations and learning about, from, and with one another, the technology needs to be used by us versus the technology using us, so to speak. And so we've kept things low tech to really focus on conversations, the curriculum being within the learning community, and really allowing for that small group, immersive, experiential type of learning. We do spend time orienting our faculty and learners to the platforms that are going to be used in advance. And we still offer a time for people to sign on early to troubleshoot, because so many people, so many of us are new to this. Some really simple things that have to be explicit and intentional. Sharing agendas well in advance so people know what to expect, and really ensuring that there are substantive breaks built in to avoid fatigue. So for example, lunch hours during a session might be an hour and a half. Breaks are 30 minutes, not 15. And we do a lot of stretch and dance breaks in between. We've been using closed captioning, especially because sometimes there's a lag in experiencing the technology. We've been encouraging learners to keep their cameras on. And in fact, when you're seeing a group of people on Zoom, for example, and I'm sorry that I have to have my slides on, I'd rather be seeing all of you. There's a level of focus and intimacy that we're experiencing in the learning that actually I think is something that is a bonus to the online learning environment. When we're in a classroom, there are so many distractions, our phones, chatting with the person next to you. People have their backs to you, but on the Zoom environment, everyone is face first. And so keeping the cameras on actually has created a sense, as I said, of intimacy and focus. And from an interprofessional point of view, making sure that people can see which profession is speaking, and of course, first and last names. So those are the kind of 4 pearls that I wanted to share with you through some of the work that we've been engaged in at the Center for Interprofessional Education and at Michener and the University Health Network, along, as I said, with our partners across the health sciences at U of T and many of the Tassone hospitals. But I just wanted to spend a moment sharing some thoughts about what we're looking ahead to. And I had a chance to chat with one of our education scientists at the Wilson Center for Research in Education at UHN, Dr. Paula Rowland, who does a lot of work in the area of team-based learning, patient and client engagement, and quality and safety. And one of the things we were talking about is that the approach to teaching and learning during COVID in the service of providing better care individually and as teams is creating a whole lot of research questions, as Paula said. And it's also disrupting some of our canons of education science. So a couple of examples, teams need time to develop. There isn't a lot of time. So how can we rapidly help our teams to get to a point of performing? Collaboration takes time. Well, we've been experimenting greatly with this concept of rapid collaboration. And in order for transformative learning to happen, typically it happens in a face-to-face environment. So how can we think about creating that kind of psychologically safe space where people can experience, as Mesereau says, a disorienting dilemma, where they can be vulnerable to share, where they can be challenged with their biases and values and assumptions that we often make in our lives. And at the same time, the speed of information is changing and our leaders are making high stakes decisions under pressure, both for our students and for the patients and clients and residents that we're caring for. So from a research and scholarship point of view, this is really providing us with having to have new ways of thinking about how we impart and support learning and knowledge mobilization. That won't just serve us during this particular pandemic or this particular wave, but how we continue to use what we're learning as we live and learn in a rapidly changing world, much more broadly. And so I wanted to share just a few more pearls that have been critical to all of the vignettes that I've shared with you today. And I feel this, as I said right at the beginning, the opportunity to just stop, prepare for this presentation, and reflect on what we've been doing has been incredibly energizing for me. Innovation can be energizing. Having that purpose that's coupled with passion for doing something meaningful during this time has been incredible to watch in terms of galvanizing people. People have had tremendous energy. And at the same time, we've had to really pay attention to the resilience of our team members. As I said, people have been working long days, obviously in care environments and in long-term care environments, but on the education front, the same is true. And so really paying attention as leaders to those moments when we hit the wall, and I've hit the wall several times, building redundancy into our teamwork, and having trusted colleagues that you can have those vulnerable conversations with to say, I am not at my best today. Can you cover me? Or recognizing that our best looks different every day. Having that sense of compassion for oneself and for one another, and the humility to realize we don't have all the answers. We may not get it right. We are doing our best and we'll adapt as we go. And building trust in our collaborations and partnerships. It's been phenomenal to watch silos coming down that have existed for a long time in healthcare and health professions education. I hope that's one of the things that gets institutionalized. Not all of them have come down, but many have, because we've got that passionate purpose that is grounding our work. Another pearl is this notion of developmental evaluation and generative questions. In my leadership work, I very much follow the tenet of strengths-based leadership, no surprise, based on what I've been sharing with you so far, but really building in a developmental evaluation methodology right from the get-go in all of these projects. We've been guided by our program evaluation expert, Dr. Catherine Parker at Holland Bloorview, who has been doing work in DE, developmental evaluation, for over a decade. And so we've been asking questions right from the get-go in all of our provincial task force meetings, in all of our debriefs around these projects. What is working well? What are we noticing? What's emerging in the environment that we need to pay attention to? And what is needed now? How can we be in service? And these are the types of questions that we've been asking all along. Over communication. I mentioned onboarding 192 hospitals in the province through their IT leads to make sure that they knew about the COVID Care Learning platform. It was communicated by the Ontario Hospital Association to every long-term care home. We made sure that there was communication to every chief nursing officer in the province, every director or VP of education, and every chief medical officer and CEO. And here we are in wave 2, and I'm continuing to get requests from hospitals asking, can we access the COVID Care Learning platform? Is there an access code? Has it been shared with our hospital? And so there is not enough good and pointed communication to get the word out. And I'll just end with this notion of how simple it is, and how, when we're focused on the tasks of our work, it's so easy to forget to just take moments to recognize people, to say thank you, and to celebrate the work that's been done. And I will be completely transparent. We probably haven't taken enough moments to celebrate. We will. But I try really hard when there's an opportunity to profile and recognize the people, particularly the hidden figures, the people behind the scenes who've enabled this good work. It's an important thing to remember. So on that note of gratitude, thank you so much for inviting me to share our experience over the last 9 months or so. And as we move into the questions and facilitated discussion, I'd also appreciate your thoughts. So I'm going to ask you a question on, given what you've been hearing from me today and just reflecting on your own experiences, whether you're working in a hospital, you're working in education, or you are living your life in the community, what do we as a community need to institutionalize in our post-pandemic world? So over to you, Laura.
Thank you so much, Maria. That was a really, really great, really informative presentation. I'm going to start, there's one chat question that I'm going to start with here. And I apologize, there's a little bit of noise in my background. I apologize. Do you know who taught the military staff who were deployed into Ontario and Quebec long-term care homes?
I don't know the full response to that. We were asked by the Ministry of Long-Term Care and the Ministry of Health if we would make the COVID Care Learning resources available to the military as they were sent into the 5 long-term care facilities in Ontario, and we did make those available. The extent to which they were taken up, we weren't doing that level of tracking, but I can say with confidence that they were there as one support to our Canadian military personnel.
That's great, thank you. I just want to encourage anyone, if you'd like to enter a question in the chat, or if you would like to unmute your microphone to ask a question, please feel free. We don't have any more questions in the chat box as of yet. I think I was just thinking to myself that the pearls you were sharing at the end there really have so much application, you know, beyond healthcare and health education, just for everyone right now during COVID. So I really appreciated those. It was really helpful. Does anyone else have any other questions or like to add to the discussion today? We'd love to hear from you.
Well, it's Leslie. I have to say something. Maria and I have known each other for a long time, but I haven't seen her in ages. So I just wanted to say what an extraordinary amount of work you've done. I mean, it really is commendable. Can you hear me all right?
I can.
Yeah, okay.
Great to see you, Leslie.
Yeah, it's wonderful to see you. It doesn't surprise me one bit that you've made this happen. It's just who you are. But you have, you know, you exemplify teamwork and you sort of live and breathe the whole interprofessional education. I know that. But, you know, if ever there was a time when we needed to bring people together to, as you say, set aside their silos and realize that in order to get through this together, we needed to work together. I just think it's extraordinary what you've done. I'm very impressed. I'm on a hospital board, and of course, my question is, you know, does our hospital have access to this? I have no idea, but I'm going to find out.
Great. And you know where to find me if you need to get the hospital access. I mean, we know there's been, so first of all, thank you for your lovely comments. And as I said, it's been a team. Just the COVID Care Learning platform alone is over 60 people and organizations. But I will say, I think one of the things that positioned us really well to lead this work together is the deep and broad relationships we have created over the last decade at the Center for Interprofessional Education at the university. We work with every Tassone hospital. We work across all of the health sciences faculties. And so being in a place in the system where we know how the Tassone CNEs work and the Tassone medical officers, and that these structures exist, and that the CEOs sit at a table and that the deans have a table, we were quickly able to kind of galvanize existing structures to enable the work and get really good advice on what was needed. So that decade of relationship building was really important.
Right. You had the networks, but you also had the credibility. You had credibility with people. That they could trust that you knew what you were doing and that it would be based on evidence. So I do think, I know humility was one of the things you had in there, but I'm sure you had most of it for yourself.
Well, you know, it's an interesting thought, because there were moments where I thought to myself, for example, so we had 10 days to launch the first version of the platform. We originally had 14 days, and 4 days is a lot of time when you're working this fast. But the Toronto Region Steering Committee over a weekend saw that the numbers were just rising really fast. And they said, you no longer have 14 days, you've got 10, do the best you can, and don't let great be the enemy of good. I remember hearing that from the steering committee. And it meant that over the weekend, 3 of us, not the whole task force, had to make a decision to pivot the strategy. So originally the site wasn't going to be a tile for every profession. It was going to be a lot more integrated and team-based. But we needed to move, and some executive decisions had to be made. And I remember going to the task force on that Monday morning, feeling a little nervous about, like, this is not the way I normally lead. This isn't collaborative. And that was the initial spark of, how do I still be transparent about what's happening behind the scenes, honor the relationships, but take those moments when decisions have to be made and think about, what does rapid collaboration look like today? So we've been thinking hard about some of those things, but that modeling and that level of transparency, I think, has built the trust within the teams and the task forces to get the work done.
Thank you so much. I'm just going to offer a couple of other questions that have come in from the chat. I know you talked a little bit about evaluation. So we have a couple questions about tracking the use of the COVID education. So have you tracked the use within the long-term care system specifically? And have you been able to track the use of the site outside of the GTA?
So for COVID Care Learning, yes, we've got what I call some rudimentary tracking because that was what was needed at the time. So we're able to track by local health integration network, and we have confidence based on those numbers that we've reached all 14 LHINs, which means essentially the whole province. But when we look at those numbers, they match with where the highest cases have been. So in Northwestern Ontario, there's uptake, but not to the level that you would see in the Central LHIN or the Central Toronto LHIN or the LHINs just outside of the GTA or places like Ottawa. So there's been really good provincial reach. We're also able to track by profession. So we know that the highest number of users are nurses, physicians, respiratory therapists, physios, and that comes back to kind of, not to differentiate the different roles, but there are members that are kind of core to the teams and members who cross a number of teams within practice. So we seem to be hitting the mark from a professional point of view. We did have the ability to track by organization, but as the platform got bigger and became provincial, we had to lose that capability just to get the new design launched. So I can't tell you how many are from long-term care and how many are from acute care, but we could probably dig into the data if we needed to.
That's great, thank you. Does anyone else have any other questions? We have a member here who has noted that they hope the collaboration works just as well with the rollout of the vaccines, which I think we're all hoping for, of course.
Yes, yes. Maybe they need to give that contract to the U of T and the Tassone network. I'm kidding.
Does anyone else have any other questions or comments they'd like to provide at this time?
And I'd love any of your thoughts on that question that I asked around, what are you seeing and learning and noticing that we really need to institutionalize? I don't think we can go back to the way we were. And I do think this pandemic has provided us with a few silver linings on the teaching and learning front and on the care front. I mean, a really good example is the tremendous job our hospitals have been doing, even to use iPads to link family members and loved ones in care, in connecting with patients and residents, but also after death. I mean, just some incredibly powerful stories of how families are being brought into health and care environments. So I'd love to hear from you if you have ideas about things we should be institutionalizing based on your experience and perspectives, things that haven't come up in the chat today.
Could I just because I'm no longer in the Toronto area, I'm outside of it. So one of the things when you're talking about community, it's different when you don't have the resources of the Toronto area around you. And so I'm really hoping that I can provide, the whole idea of interprofessional education is still new to many hospitals outside of the Toronto area. I hate to say, but it is still. I think they know what they're doing, and I don't believe that they are actually doing it. So using this as a model to actually truly embed it or encourage the embedding of an interprofessional education perspective or interprofessional practice way of operating could be a game changer for some of these hospitals that are, as I said, they're not Tassone hospitals, they're outside.
Yeah.
And we need that level of evidence in these other hospitals. This is such important work, and I'm just sorry, I'm really speaking for my own community that this is what I would really like to see here.
Yeah.
So.
Thank you, Leslie, and happy to support in any way we can.
Anyone else have any other questions or thoughts for Maria? Okay, well, if there aren't any other questions, I just want to thank all of you for attending today. This is a really, really great discussion. Of course, I want to thank Maria so much for your time today and for sharing the incredible work that you're doing. And I think we can all really feel the impact of it. And I know we will continue to feel it. So I really appreciate you sharing this with our alumni community today. Of course, I want to thank Laerdal Medical as well for sponsoring our Lunch and Learn series. This is the final Lunch and Learn for 2020, and we look forward to sharing more information on what's planned for 2021 soon. I also want to thank Shauna Spicer and the Bloomberg Nursing IT department. What would all of us do without our IT departments during this time? We're really grateful for their support with this. And I just want to say thank you again to all of you, and I hope you enjoy the rest of your day.
Thanks, Laura. Have a good day. Stay safe, everyone.
Thank you so much.
And we're still on. Okay, the picture's gone. So that's good.
Eve. Eve, there we go.